Right, so why don't we get started? So let's talk about what Apnea is. So it's not your typical practice management software that just is focused on sleep and dental sleep medicine. This is actually a platform that connects both dentists and physicians with patients and connects the doctors with the supporting companies such as sleep labs, home sleep study labs, physicians that practice sleep medicine and diagnose sleep apnea, dental appliance companies like Somnomed that provide oral appliances. So this is a platform where it truly is a full service turnkey dental sleep medicine practice management software with tremendous amount of analytics. So Apnea is truly an enterprise level. That means it can be scaled to multiple practices, global, since it's cloud-based. It's a comprehensive end-to-end dedicated solely to dental sleep medicine. So electronic medical records and patient and practice management system with predictive treatment planning and guided workflow. And we do this using tremendous amounts of patient-specific multivariate data point analytics, and we use machine learning and artificial intelligence to create the dynamic workflow step by step. With Apnea, you have education for both the doctors and team, certification course. We provide marketing and networking with physicians, sleep, and dental labs. There is our proprietary predictive patient screening, Sleep SWOT, which is pretty incredible. We do have a pediatric specific component to the educational platform. So Sleep SWOT, as you will see a little bit later, is a much more predictive patient screening tool. And we just got the US Patent Office to grant us a copyright for it, which is fantastic. And then, of course, we have this guided and automated clinical administrative workflow. So it's literally step by step. And a predictive analytic that determines the ideal job position for maximum oral appliance therapy efficacy. And we can prospectively, from the very first visit of clinical evaluation, predict that positioning. What that means is that when you take that bite, that mat fit three-dimensional bite, and send that to the lab, you get back an appliance that really doesn't need to be titrated much. Standard deviation is 0.7 millimeters. That's 0.7 millimeters of titration to treatment efficacy, as defined by the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine. And that's pretty remarkable. And of course, then the major headache with the medical billing, the platform does that and assists the dentist with the medical billing component of it and all of the regulatory and compliance aspects of the practice of dental sleep medicine. And tremendous amounts of support and documentation support and solutions are available to our members. Our mission was to actually bring about, the whole project started literally almost 20 years ago now, when we decided to bring about objectivity to the practice of dental sleep medicine through educating our colleagues using accurate research, state-of-the-art treatment protocols so they can help their patients. And obstructive sleep apnea is just not a disease process of the developed nations. It's just not an epidemic that the US population is facing. It's a global epidemic. It's estimated by the WHO that almost 1 billion people across the planet suffer from this disease. We took it upon ourselves to create a system that any dentist anywhere in the world could easily use to help their patients and treat their patients in the most effective manner without the need for any sophisticated equipment or expensive unnecessary equipment. And connecting the physicians and the dentists was the evolution of creating this platform, because we need physicians to partner with dentists for the diagnosis part of it and the referral part of it. So we've created that network, and we're still creating that network. So as I mentioned, sleep apnea is a disease process that comprises of chronic interruption of breathing for 10 seconds or more during sleep. So each interval of stopping of breathing for 10 seconds or longer is considered as an event. And we track these events over the full night. And people who suffer from sleep apnea experience these events at a very alarming rate, as many as, sometimes even 120, which is incredible, because that's 1 every 30 seconds. People stop breathing for 10 seconds or longer, little as 5. And we can go through that a little bit later. That's what we call the AHI. People can stop breathing hundreds of times a night, and for decades. And as we get older, the incidence actually gets worse. The severity gets worse. So, and the untreated condition can lead to severe and serious, even life-threatening health problems. And it's pretty remarkable at what rate are we experiencing this disease in our general population. It's now just the ADA last week in their morning huddle daily report that they published and emailed to all their members reported that a recent study estimated that it was 37% of adults in this country suffer from obstructive sleep apnea, and 80% of them don't even know that they do. And of the 20% that have been diagnosed, an alarming rate of 85% of them are prescribed a CPAP. And even then, the 85% that are prescribed CPAP, 1 out of 4 actually accept it from the onset. That means 3 out of 4 patients who are prescribed a CPAP actually refuse it without even trying. And the 1 out of 4 that actually do try, the compliance at 1 year mark is 1/3 of them. So just imagine how much is this oral appliance therapy needed to satisfy the management of these large cases of sleep apnea in this country alone. Has been related to increased in healthcare costs, and a 15-fold increase in traffic accidents, and a higher incidence of absenteeism from work. And that all comes down to decreased GDP. In the general population, as I mentioned, 85% are prescribed, actually 80% are undiagnosed, 85% are prescribed CPAP. Oral appliances are only prescribed at 10%, but even that in the studies don't disclose if the 10% were the first round of therapy that were prescribed, or these people were prescribed oral appliances after they failed a CPAP. So that's not clear. So just imagine that. And surgery, which is completely irreversible, very effective if you have the right case selection process, is prescribed at 5%, but lifestyle is prescribed at 100% of those cases. So if you're going to build a dental sleep medicine practice, and I think, hi Dale, I think it was Greg, if it was you, I think, who said that he's been practicing dental sleep medicine for the past, now 7 years, which is amazing, which is great. You know that physician referrals are important, but you have a tremendous gold mine of patients within your own practice, and if you don't take advantage of them, these patients are going untreated. So screening your own patient population is absolutely the key. So if you just look at statistics, 1 out of 5 adult patients suffers from sleep apnea conservatively. 1 out of 8 pediatric patients suffer from sleep apnea. In a typical dental practice of 1,000 adult patients, 200 estimated have sleep apnea, and of those, 160 are undiagnosed. And of the 40 that are diagnosed at 1 year mark, the compliance is 1.5% of the 40. So think about the oral appliance opportunity. It's 185, and that's tremendous. And we know that dental sleep medicine, when it's practiced correctly, can have a higher ROI yield than, say, Invisalign. So we did our first webinar, and I encourage all of you to visit the webinars. They're on our website, and they're on our YouTube channel, on our podcast channel. But just to summarize, for those who are new to apnea, the first webinar was all about how to screen your patients, and we will go into the top 6 barriers. When we surveyed over 1,000 dentists, we had the top 6 reasons why they didn't want to practice dental sleep medicine or incorporate that into the daily practice, and each webinar addressed one of those issues. So the top 6 were lack of education at a graduate and postgraduate levels, so it wasn't taught in dental schools or residencies or even postgraduate. And then, of course, the low sensitivity and the specificity in patient screening. We know that if you just use Epworth Sleepiness Scale, that 60% of patients who are diagnosed who actually suffer from sleep apnea don't even report any daytime sleepiness symptoms. And of course, then the other one was the arbitrary determination of a start mandibular position just by literally taking a percentage of the range of motion followed by a subjective trial and error titration of the appliance. That's not very scientific. And of course, if you're just guessing on therapy, then the oral appliance therapy, the efficacy is inconsistent. It's a hit or miss. And then, of course, the fragmented clinical administrative solutions, there isn't a defined workflow. You can get software, you can buy software, you can license software that deals with just the administrative part of it, with the record management. You can buy expensive equipments like the rhinometer and the pharyngometer that deals with the clinical part of it and tries to give you some kind of a determination of where to start. But there isn't one system that actually addresses every single component of a practice management software. And then, of course, medical billing. Our system addresses that via an automated process. So we know that hygienists and dentists can screen and then refer for a sleep study. And as part of our process, the dentist can do the face-to-face If you're worried about Medicare, where there's a face-to-face in the Medicare guidelines, it's all on our website, from their position paper that dentists can have that face-to-face. And the oral appliance therapy for Medicare patients should be done by dentists. Not by physicians, by dentists alone. But dentists can screen and do that face-to-face and refer for a sleep study. Our screening methodologies, the sleep SWOT and the stop bang, which the hygienist uses, but the sleep SWOT the patient fills out in the treatment room or in the reception area. And then we talked about the predictors. Webinar number 2 was how to establish and document patients' candidacy for oral appliance therapy, and the refer for diagnosis. And this was all about that required face-to-face consultation. That's absolutely required, and as part of the workflow, it's all there. So we talked about that in the second webinar, and the referral to a physician for a sleep study. All that stuff was discussed. And then in webinar number 3, we talked about how to obtain medical insurance predetermination and complete the medical insurance claim form. So here are the guidelines, the Medicare guidelines, where it says that that dentists can do the face-to-face. And then, of course, we talked about the webinar number 4, which was the clinical workup and how to use the Andra gauge, which is a 3-dimensional gauge, to record that ideal 3-dimensional jaw position for oral appliance therapy. We talked about how to use the Andra gauge, the differences between the George gauge and the Andra gauge, and how to record the mat fit bite using the Andra gauge, and how to choose the right appliance for the case. So according to Medicare, CMS, dentists are the ones that should treat the patient with an oral appliance. And the materials, we discussed what materials you need. So we built this system for the dentist that doesn't have pretty much access to a lot of stuff. There are parts of this world where the dentists that are practicing who don't have access to cone beam x-rays or rhinometers, pharyngometers, or matrix, or any of that stuff. So how do they actually practice dental sleep medicine in the most predictable and effective way? And that's what we have done. So this is pretty much everything you have in a typical dental practice. Perhaps not the same brand of a camera, but usually a digital camera or any kind of a camera will do the job. So we need a stethoscope to be able to listen to joint sounds. We need a ruler to measure certain dental range of motions. We have a caliper, which most dental practices have, and Mirror Explorer Pro to document certain measurements, retractors and mirrors for photographs. And these are the kind of photographs that we normally take and document and archive in the patient's chart in our platform. So this way we actually document the baseline and the materials that are needed to take a mat fit bite. If you are not a digital practice using an intraoral scanner, you literally have everything here except for the Andra gauge. But if you get the Andra gauge, you have the impression materials, you have the assortment of impression trays, you have bite registration material, you have dispensing guns, you have all that stuff currently, and you don't need anything else. And for those of you who are new to the platform, the Andra gauge can be ordered through Ohlendorf Labs, and it literally costs $10. We talked about the necessity to manage the case long term. So it's not enough that we simply insert the appliance. It's more important to actually follow up with the patient at a predetermined interval to make sure that the treatment is working. Number 2, that the patient is compliant. Number 3, that the patient is not experiencing any untoward side effect of oral appliance therapy. And there have been many reported, and we will actually go through that today. So today's webinar, it's all about Appliance Insertion Visit and the follow-up. So last webinar, we actually took the bite, we sent it to the lab, and now we have the appliance back. What do we do now? So again, what do we need for that visit? What do we actually need for that visit? Well, we need the same exact stuff that you have. We need retractors and we need a camera. Why do we need that? Because we need to document the insertion of the appliance, and we need to document warning repositioner, and that's how we do it. So we need to document that because now that's a photographic evidence of what you did. In case there's ever a dispute, we have these photographs to actually fall back on. So why don't we go live and start the process as it occurs in the platform. So this is our dashboard in our patient's, this is our patient's chart in our dashboard. And what we did last time was we did the workup and we sent out for the prescription. Now we have the appliance and it's ready for the appliance insertion. So we simply access, so realize something, anything that's pending that has to be done shows up in red with a pencil mark next to it, which means it's ready to be completed, to be filled out. Anything that has been filled out is in green with an eyeball that means it's read only. So as you may have noticed that there are a whole bunch of these forms that need to be completed, and they're categorized per visit. So the initial consultation visit, the pre-authorization form, the clinical evaluation visit. Now it's the insertion visit. So every visit, so it comes step by step. You really won't get the pre-authorization visit forms if you haven't completed the initial consultation forms. You will not get to the insertion visit forms if you haven't completed the previous evaluation visit form, which is all about the workup and then referring for an oral appliance therapy. So from last time, we prescribed a Somnomed Air Plus with a soft liner, and as part of our protocol, every appliance by default is ordered with a morning repositioner, and we'll go over that in just a few minutes, the importance of the morning repositioner. So again, we get the appliance, and we, number one, check, of course, like anything else, we check for any breaks, anything that will cause us not to proceed with the insertion of the appliance. Something is missing, it's broken, perhaps it's not the appliance that we asked for, and that can happen sometimes. So as part of the workflow, we kind of tell you the system kind of tells you what you had ordered. So it migrates that information from the previous forms to this form, so you know that what to look for. Then of course, you try in the appliance and you make sure that it fits. If the fit is acceptable, you click it. If it's not acceptable, then it asks you what's not acceptable. Is it the lower part of it, the upper part of it, or both of them are not acceptable? And do you want to send the appliance back? Right? And this is a very dynamic workflow. So realize something. If the appliance fits acceptable, then you can actually proceed to the next steps. If it's not acceptable, it'll ask you what you want to do with it. If you want to send it back, and then right there, do you want to send it back for adjustments, or do you want a brand new appliance remade? And if you do that, then you can generate a new lab prescription right from here. But in the event, let's assume the appliance fit is acceptable. By default, the morning splint is here, and the instructions, it's pretty cool. You will notice once you complete this, the instructions are actually emailed to the patient. You also have the opportunity to download it. It will give you a prompt to download the instructions and hand it to the patient. In the event the patient prefers a physical form rather than a virtual, but it just literally goes step by step. We use the algorithm as the initial appliance setting. Was there any additional titration required at this visit? Yes or no? If it was no, then you're not able to enter them, as you see. But if it's a yes, then you can. Was it backwards? Was it forwards? Was it up and down, left and right? But realize something. Every single oral appliance on the market today can only be adjusted in one dimension. Front and back, forward and back. We just received patent pending for our oral appliance that actually can be adjusted in all three dimensions. That's pretty remarkable. Ed asks, is the soft liner very secure? Yes, it's really gripping. It's really preferable. I use the one with the soft liner because I like the softness of the inside, but yet the hardness of the outside. So think of the hard, soft night guard. It's much more comfortable around my teeth, and that's what I like. And yes, it's very retentive. We don't need to use a ball clasp or an Adams clasp or any other securing method because the way the soft liner is built into the appliance, it's done on the model itself. Could be a physical model or a 3D printed model, but it's actually done. The process is pretty cool, and it's really very secure. So anyways, you can actually do that. Additional titration require. You can write down 1 millimeter or whatever it is. So you can actually do that. But in the event it's a no, that's fine. Oral splint, the morning repositioner instructions given, yes, because by default it will email it to the patient, but it will also give you the opportunity to download and hand it to them. And it also tells you what the pre-treatment clinical photographs of the patient. So you can actually, if you didn't have the opportunity in the previous visit to upload the photographs, because that's when you actually took the photographs and perhaps you didn't have the time to download it onto your desktop, then upload it, and you said we'll just do it next time, this is the time. So by now you would have had the x-rays on your desktop, the photographs on your desktop, and you can import them. And this is important. So, we actually take photographs, unlike for orthodontic reasons, unlike for orthodontics, when you actually just take a full face, but not a full body. For sleep apnea, it's very important that we document what the patient's presentation is in full feature. So Ed asks, at insertion appointment, how would you know if it needs titration? We don't, but it's part of the workflow. We made it so that, we have dentists of all experience levels, and some people like to, for whatever reason, titrate it. They try to back it up a little bit because for whatever reason they think it might be too uncomfortable or whatever it is. But they have we give dentists guidelines. We can't dictate how they practice. All we can do is give them, guidelines based on science. But yet they're left to do what they feel they want to do. And as long as they document what they're doing, we're okay with it. And it's actually very important for that purpose that we document what we do, because it's important to actually keep a track of all the titrations that we're doing, if that, or any kind of change we're making. It's important to document. It's not just important to document that we're doing it, it's even more important to document how much of a change we made. Okay, so again, you have the opportunity to import the photographs. We document this format because this way, after successful treatment, the patient usually reports being more energetic, so they start to lose weight. And as part of the as part of the consultation is patients have to do their part in managing their weight. That means eating right, exercising, and once they start to get a good night's sleep, they wake up more refreshed, they have energy during the day where they don't have to sleep or take a nap in the middle of the day. They can then go to the gym for 15 minutes or walk that 15-20 minutes, and you will actually see at 1 year mark that the patient comes back with weight loss, which is tremendous. And how powerful is it to actually show the patient what they used to look like? So we normally we document, of course, the baseline of their occlusal scheme, but we also document the airway, the resting tongue position, when they say ah in the Malapati classification. Anything else that was done, so we document it here. And then, of course, the treatment plan is delivery of their appliance. We did that. We gave them the appliance and the morning repositioner. The treatment plan would be accommodate to appliance for several days. If the dentist feels that they want to give instructions, they have this instructions, but normally we recommend not to. The treatment plan is follow-up after insertion of appliance, and you can just continue to check, schedule the patient, we'll continue to evaluate the patient, schedule periodic visits, schedule pay for periodic visits, or refer for, a sleep study. Right from here, if you feel comfortable, you can actually refer the patient for a sleep study. And by just simply doing, selecting to a partner sleep physician or a sleep physician that you normally work with, or for home sleep study. So like anything else, if you refer for an in-lab sleep study or to a physician for a sleep study, you can choose the lab from your preferences or from our network of providers. You can also, the dentist can also refer the patient to one of their preferred labs. They can refer it out, or they can, for some dentists who actually have the sleep study equipment in-house, they can give it to the patients in-house or refer out, and right from here they can refer it out to whomever. Let's assume in the next day, as part of the course, you will notice that it's usually 1 week that we want to see a follow-up. If we see something that needs a referral, we can refer the patient for whatever it is to whoever, and we save and continue. So if you remember, we referred the patient for an efficacy sleep study, and that's the next step. And now it's no longer a diagnostic in-lab or a home sleep study. It's actually an efficacy sleep study. So we can actually do a titration study if we want. We don't have to, but here's an efficacy sleep study. All the data that's necessary for the lab in terms of the BMI, the AHI, their symptoms that they're presented with in the beginning, all that stuff is here. And here's your sleep study referral letter. And when you save and continue, if it's a partner lab, then here we go, they can do that. And once you've completed this form, then all of a sudden when you do save and continue, then you have you can generate the sleep study, which you did. You can generate the insurance form, because you can only technically bill for this procedure after you've done the insertion of the appliance. And then of course you have to download the proof of delivery of appliance. By the way, the patient also gets that proof of delivery of appliance. And when you do that, and here is the proof of delivery of the appliance, and the patient's name, the insurance company. The patient literally signs off that they have received the oral appliance in good condition, was custom made to fit their mouth. This can be sent to the insurance company as proof that the appliance was delivered. The patient signs it, dates it. If there's a witness, they sign it, date it, and that's what goes to the insurance company. And right from here, you can actually generate the insurance form. And that's simple. So, because of time, we're not going to do this, but it's pretty straightforward. The first primary diagnosis of obstructive sleep apnea, the second diagnosis bruxism, the third diagnosis could be snoring, whatever it is. The first is oral appliance therapy. We did a full mat series. We did And the great part about this is it actually tracks when you did it, so those dates populate by itself. We did a home sleep study. We did study models, consultation level, all that stuff. As you can see, you can customize, you can edit this whichever way you want. When that's all is done, I'm just going to skip through a lot of stuff, but realize something just for the illustrative purposes. You save and download, and we can just move this out, Save and download. There we go. Here we go. There it is. So it took a little time, but here's a primary insurance form, CPAP intolerance affidavit, consent form. All these you have an option to click and download because all these supporting documents. So if you do this, and you do this. So as you can see, here's the CMS Insurance Form. And that's your medical insurance claim form. We had 3 diagnoses, as you can see. These are all the treatments, the fees, all that stuff comes in, and all you have to do is just literally just print it and send it. And when it comes to the CPAP intolerance, it's already there. And the informed consent, that was part of the workflow from previous visits. It's right here, which the patient signed and dated. So all these things are done automated, so you don't really have to think about what needs to be done next. How are we doing? Great. So we've done this, and now what we have to do now is go to case detail, because now we've done the insertion, and the next step, here we go, the next step is the insertion follow-up visit. As you can see, we did the insertion, now it's the insertion follow-up visit. And the same thing, which is a week later. You record, like anything else, your base vitals, your blood pressure, your pulse, the weight of the patient. You know what appliance you did, when you inserted it. It tells you how long since the last insertion, the date of the last visit. Initial settings was mat fit because we defined that is an additional titration time of insertion, yes or no. It was no. Any additional titration today, yes or no? We can do that. If it's yes, then we have the ability to do so. Could be whatever, left, right, down. It could be no, and it's a no. Is the appliance in poor condition, needs to be replaced immediately? The appliance is showing signs of wear, whatever it is at this time. Appliance is in good condition. We just have to document it because you never know. The patient may have just not ignored the 1-week follow-up and they were feeling fine, they were feeling happy, and now all of a sudden, a year later, they come in. We need to still kind of document all that stuff. We need to document the condition of the appliance, the periodontal status. Has the periodontal status changed or unchanged? If it's changed, then what has changed? The interproximal contact, as it's changed, because there can be some migration of teeth. We just need to document if it's changed, what has changed. If it's unchanged, we at this point have the x-rays from pre-treatment. We have the pre-treatment photographs, so we can actually look at this and look in the patient's mouth and correlate and see if there have been any changes. What's the assessment? Have we obstructive sleep apnea? Have we managed it? And the snoring, have we controlled it? Is the patient still snoring? And if the patient's still snoring, what are we going to do about it? If they need some kind of soft tissue surgery, we can refer right from here. If not, and they're controlled, we don't have to. Assessment is the patient progressing well with oral appliance, and then additional procedures if we did anything, and the treatment plan is just to reevaluate the patient in months, in 3 months. So the interval is 1 week for a follow-up, 3 months, 6 months, 1 year, and then annual after that. And if we didn't send out for a sleep study last visit and we want to do it now, we can do the same thing. We can schedule the patient, we can oral appliance therapy efficacy needed, we can do a home sleep study, we can do refer out, we can do, let's say, a test. And we can write from here, we'd like to see the patient in, let's say 3 months. Referring to save and continue. Here's the oral appliance efficacy sleep study request. If it's to a lab that is not part of our network, then you have to download and send it. But if it's part of our network, if the lab is part of our network, or if the physician is part of our network, then this form electronically gets sent to their inbox. So in their dashboard, it will appear as a referral. Similar to if a physician refers a patient to you and the physician is part of the Apnea network and they refer to you within the platform, then there's no need to fax or email referral letters or anything. They simply refer from their dashboard. You get an email alert saying a patient has been referred. You log into your dashboard and the patient's chart is in your dashboard for you to review. So you save and continue. And then of course the next step, if you notice, is the insertion follow-up. So you just keep doing follow-ups, and each follow-up you keep documenting anything. So this continues. This will continue until the patient is, literally forever. Just like you would want that patient to be in your practice, even if they're not part of your practice, to at least be in contact with you, since you're treating their medical condition as a treating physician. And by CMS guidelines for oral appliance therapy for dental sleep medicine, you are a physician. Their classification of physicians are treating physician is any physician, any licensed practitioner qualified to treat oral appliance therapy. Dentists, DMD, DDS, even physicians, ENTs, as long as they're qualified. But per their guidelines, it's recommended that a dentist do the oral appliance therapy. So for that purpose, for the purpose of the definition, dentists are physicians that can treat oral appliance therapy. So you just continue. You just continue. Okay? So you can continue doing that. So why don't we go back? How's everyone doing? Excellent. So let's show you what the next dashboard would be. So remember that patient? That patient is no longer in treatment, but in follow-ups now. Because now the patient is no longer in treatment, now you're just following up on the treatment. So the patient's now going to show up in your follow-up folder. And if you see that we had done the we had done the appliance insertion visit. That was the first form you actually saw. There was nothing else available for you. Then the next one was the appliance insertion follow-up visit, and then we did the efficacy sleep study request, and now the next is the long-term follow-up visit. So as you can see, you can just continue one by one and continue indefinitely, evaluating and making sure the patient is compliant and the treatment that you prescribed is working. So let's go back to perhaps talking a little bit about managing some of the complications that people experience, that patients experience with oral appliance therapy. Okay, is that good? Can we go back to the presentation? This is how many patients keep appliance in all night versus taking them out without knowing. So in our study, in our published studies, the typical compliance and compliance is defined with by the same definition of CPAP, is you have to wear it for more than 4 hours each night. So typically an oral appliance has a compliance rate of about 72%, but our MatFit appliances, because they're titrated to an exact amount, the people actually find the benefit and they have a better sleep. They go through better REM sleep with a MatFit titrated appliance. We actually have a 94% compliance And we know that because, as you can see, as part of the follow-up, which I forgot to mention, is the patient has their own set of follow-up forms. So if I showed you this, so the patient post-examination, post-insertion follow-up. So appliance insertion follow-up visit. So here the patient initially had completed their chief complaints, and now we ask them to fill out the same set of questionnaires, and they know what they had originally reported. So now difficulty constant, because now that they're compliant and they're feeling better, what is their chief complaint? So imagine daytime sleepiness was high on their priority level, and they had a lot of concern about them experiencing daytime sleepiness. Now, all of a sudden, it's none or low because they're feeling better. So imagine what a powerful tool this is. But besides that, we have them take the Epworth Sleepiness Scale that they took before. We have it done again. The appliance use, we ask them about how many average number of days, weeks of use of appliance. If you use a compliance monitoring chip, we can always record that data. You can input that in here. Snoring, have they, do they feel better? Is it reduced? Is it worsened? How many number of days a week do they use? How many hours do they use? Do they sleep comfortably with the appliance in place? Yes or no? If it's yes, great. If it's no, any retention problems? Does the appliance fall out of the mouth easily? Do they notice that you dream more? Is there any tenderness to teeth? Temporomandibular joint tenderness? It documents, yes or no. Changes in tooth contact, they will report if that's the case. So we actually ask them a series of questions before they even come and see you for the follow-up. And they actually get an email notification in their inbox with links to complete this form. And then they attest to the fact that they actually fill this out. So everything that they're saying here then gets recorded and stored and archived in the patient's chart. So it's pretty detailed in terms of their part of the questionnaire and their documentation. So because we know how patients are doing, we can actually say that. But we've known that from our previous study. But now we have, even more, a larger patient pool that we can get that information from. So let's get back to the AML. As part of the informed consent, we have to disclose that there's a possibility of teeth shifting. So let me ask you a question. Why should we be concerned about whether our patients are wearing their oral appliance therapy at night or if that's effective? Worst case scenario, if they're not compliant, they get back to CPAP, right? But we know that they're not going to comply, so this is the best therapy they have. It's not just about sleeping well, right? It's about sleeping well and sleeping predictably, where they can actually get the benefit of treatment. Because this is a disease process that really can create a havoc on patients' overall health, both physical, mental, emotional, and medical health. So, and the complications of teeth migration should not be as much of a concern for the patient where they don't follow up with this treatment, because not following with treatment is going to harm them so much more in their medical health, their general health, their emotional health, than any problem from teeth shifting. Nobody ever died of a malocclusion. Nobody ever died of crooked teeth or ugly teeth or missing teeth. But people die every single day of untreated sleep apnea. So you have to weigh the risks and benefits of treatment and the complications. So the adverse effects of tooth migration should not be as serious of a concern, because the side effects of untreated sleep apnea can have adverse effects that are truly catastrophic for a patient. So like I said, if they don't comply with oral appliance because they have TMJ issues, But as part of our workup, if you go back to our previous webinars, you will notice we actually do it from a neuromuscular standpoint. We actually take into account their TMJ in our algorithm. It's very quantified, so it's not just TMJ as blanket. We actually have the dentist palpate muscle groups that, and let's take a look. What kind of a muscle groups? Let's talk about that. So teeth movement and acute jaw pain were reported in all the studies as the complications. So we actually identify specific muscle groups, and we actually take into account all these issues, the myofascial pain, the arthralgia. We take into account all that. So we actually have our dentists evaluate across multiple, let's take a look and see, here we go, muscles. So we actually have you palpate several sets of muscles: the temporalis, the masseter, the posterior digastric, the the lateral pterygoid, internal pterygoid, trapezius. I mean, a whole bunch of them. We actually have you go through and then quantify any discomfort that the patient might be experiencing and grade it on a severity scale, and all those go into an accounting in the algorithm. So all those data points are then assigned a score, a numerical score that goes into factoring into the appliance, into the mat fit titration. So if a patient has been experiencing clicking off the TM joint before treatment, but the TM disorder was not a significant enough one for them to not move forward with oral appliance therapy, because realize something, 3 out of 4 patients with sleep apnea grind their teeth, and just as many also suffer from some form of TMD, muscular, neuromuscular, and actually musculoskeletal disorder of some sort. They have myofascial pain, and trigger points, but perhaps not serious enough to exclude them from therapy. And they actually overwhelmingly get better, but there are some patients who are just continual. So what do we do about those patients who are continuing to experience discomfort or develop discomfort, let's just say, after oral appliance therapy? So we have to first identify which muscle group is what's causing the discomfort, because we can't just take a blanket statement of that they're in discomfort. We have to target the exact muscle group that's actually causing the discomfort. So, for example, a lateral pterygoid referred pain pattern. So if you look at that, the symptoms that they normally present with when they're dealing with a lateral pterygoid referred pain pattern is they complain of earaches, they complain of sinus area pain, they complain of front tooth hitting first, they can't close their molars, they have a reproducible and common symptoms of dysfunction, and all this stuff will be available afterwards. So, and we'll make this available as part of our educational platform as well. This lecture. So when we're dealing with improved compliance, everything that we can do to manage the complications, side effects, that all translates into better health for the patient. So we just have to always be reassuring the patient, saying and letting them know that all this TMJ stuff that they're experiencing as post oral appliance therapy is a short-lived process, because we are an adaptive species. Our muscles start to adapt, right? Once we figure out what the root cause of the discomfort is, and we institute the right therapy for it, could be range of motion exercises, could be massage, could be just certain things like I will show you in a bit. We can do that. So we talked about that. We talked about trigger points. Because we know that we're dealing with a muscle group, and what happens is when we shorten or elongate a muscle group beyond its physiologic limits, we start to get these builds up of acute pain disorders in these patients. And if we don't manage it early enough, then it can continue to get worse. We know that when we're dealing with a muscle group, we're dealing with sarcomeres that are normal, but then when we stretch them, and repetitive stretching and shortening can create these bands of these taut bands that can create the discomfort. But the majority of these symptoms can easily be mitigated from the very beginning if we literally, and this is how we palpate different muscle groups to figure out where the origin is. And sometimes in the palpation we can actually trigger the painful response even if they don't experience, if they're not experiencing at that moment in time. We can actually elicit painful response by palpating and manipulating that muscle. So it's important for us to just not take the answer that my jaws hurt, but to actually do a physical examination to find out actually which muscle groups are the ones that are causing the patient the discomfort that's preventing them from complying with their oral appliance therapy. Oh, okay, Ed. Thanks for sticking around. Appreciate it. You're welcome. So when we're dealing with mitigating these from the very beginning, one of the best ways to do it is to actually give the patient the morning aligner, the morning repositioner. We also can use bite tabs or chewing gum and some jaw stretches in the retrusive and stretching exercises. So as part of our protocol, the AM aligner comes pre-made from our labs, but in the event you choose an outside lab that doesn't provide you with an AM aligner, you can actually buy these boil and bite kind from a whole host of suppliers and sources. And perhaps the lab that made the oral appliance for you can also give you this in its most unaltered state that you then have to kind of boil and bite and use. And it's pretty much straightforward. You have different kinds. You can have like an NTI kind where it's making partial contact, or you can have a full contact. It's always better to have a full contact because that's, you actually balance the jaws better and you load the joints more equally. This way you prevent the rotation and translation of the jaw joint beyond its limits, So we can actually have, and we have the patient bite down fully. When we heat it up, put that plate in their mouth that's soft, we actually have them bite down where their back teeth touch each other. So it's a pretty hard bite, and then we kind of fold it to whichever arch, the upper or the lower, preferably the lower. And what it does, it literally elongates, lengthens the lateral pterygoid muscle and relieves the symptoms. And this is a prefabricated AM aligner by Somnomed. It comes like this, and it has a little, raised platform. So literally you are stretching and elongating that lateral pterygoid, giving the patient the relief. So I can't stress enough the importance of a morning repositioner, or the AM aligner as it's called. But some of the other ways you can actually combat that is by bite tabs, chewing gum. Bite tabs come in different thicknesses. You can actually have the patients chew gum in multiples, so one actual chewing gum versus 2 versus 3. The more you add, the wider the patient has to open their mouth and the harder they have to bite down. And that's just range of motion exercises, and it kind of helps with the exercising. So it's like, just imagine when you're working out with weights, the more weight you add, it may be a little discomfort, but in the long run it's beneficial. It strengthens the muscle. So don't be afraid to tell the patient that it's going to hurt, but similar to when you exercise with weights, it does hurt in the beginning, but it's actually doing a job of strengthening the muscle for the long run. So we can use bite tabs. We can even use certain thrust motions to kind of push the mandible back because it's been moved forward all night long. So we have these kinds of exercises of jaw retrusion. They sound barbaric. They're not. Actually, the patient feels improvement right away. So imagine doing somebody who has a locked jaw, and you have to kind of reposition it back and reduce that. But this is actually in a closed position, so it's almost like a closed lock, closed jaw. And don't worry about it, about the popping and the clicking. Popping and clicking by itself without any symptoms is benign. You only treat clicking and popping if it's accompanied with symptoms. So we have multiple ways of kind of creating that relief for a patient who wakes up in the morning after appliance therapy and is in a bit of a discomfort because their muscles are kind of sore and raw. We have exercise motions of moving the jaw left to right, and you can see as we move it, it causes stretching of the muscles and the ligaments. And if you exercise, you know how important stretching is before and after your exercise routine. It's very important. It actually prevents from injury. So we can do that several times. And as we know, that stretching is very important. It increases our range of motion and flexibility, and the jaws are no different. So this actually concludes the 6 barriers of implementation. So these 5 webinars covered every single reason why dentists choose not to practice dental sleep medicine. And as I showed you in this webinar, it's really not that hard to implement dental sleep medicine in your practice. So now, why don't we go ahead and start taking some questions and answers? How do you go about this for PEDS patients? So perhaps you can describe a clinical condition. Great. So as part of our certification course, the entire section of sleep, pediatric sleep medicine, I always screen my pediatric patients. Yes, as part of the educational platform, you will see all the screening tools that are available for pediatric patients. And you're right, you should be screening all your pediatric patients along with your adult patients. So yes, and then I refer them. And that's completely fine. That's completely fine, but that's on board. Well, the great part about the apnea ENTs is that they fully understand the multidisciplinary approach to managing a pediatric patient. So our ENTs are very sympathetic to the child's need for treatment. Could it be adenoid, tonsillectomies and adenoidectomies? Yes, of course. So that's great. If you're a pediatric dentist, yeah, it can be hard, and that's a great part about our ENTs. But it's just a matter of, we have tremendous amounts of letters for ENTs on our platform that you can use that are branded to your practice that you can send out to your ENTs. It educates them on the on the harmful effects of untreated sleep apnea on the pediatric patients. And even in the ENT's guidelines, in the otolaryngology guidelines, the Academy of Otolaryngology guidelines, that sleep apnea, pediatric sleep apnea patients should be treated as first round of therapy by tonsillectomy and adenoidectomies, and then maxillary expansion as second round therapy. It's in their guidelines. Actually, the first palate expander that was ever installed in a patient, in a documented installation of a palate expander in a patient, was almost 100 years ago, and it was done by an ENT on an adult patient. And the indication for that palate expander was to improve that adult patient's nasal breathing. And that's all in their journals, all documented. Yeah. So as a pediatric dentist, you're very familiar with myofascial orthopedics, with dentofacial orthopedics and growth. And even by the American Academy of Sleep Medicine, American Academy of Dental Sleep Medicine, the Pediatric Association, and the ENT themselves, everyone agrees that that kids should be screened when there are certain symptoms present, such as grinding their teeth past age of 6, 7, after they've gotten their first molars, bedwetting, ADHD, all that stuff. That they should be screened. Obesity, they should be screened. Snoring, they should be screened, and then evaluated for number 1. Tonsillectomies and adenoidectomies as first round of therapy, and then palate expander as second round, because we know that the palate is the floor to the nasal base, and when we expand the palate, we actually expand the nasal base and improve nasal breathing. That's not even for dispute anymore. Enough articles, research has documented and proven that to be true. So if you have ENTs in your area, I would welcome you to send them the letters that are in your section letters for the physicians, and let's see what they have to say. But it's the more progressive ENTs, at least the ones that we're dealing with, and perhaps we're biased because we are ENTs on apnea that are very progressive, otherwise they wouldn't have migrated to apnea, but they fully understand the correlation and the link and the partnership with dentists for treating their patient, the mutual patient. The history of TMD actually on the reverse, and this is the Orthodontic Society will never admit to it, but serial extractions and retraction orthodontics actually closes the oral cavity. It actually makes it narrower and smaller, and that's less room for the tongue. So as the child grows into an adult, that small cramped space doesn't get any larger in proportion to the size of their tongue, because the tongue continues to grow at its rate, but we have retarded the growth of the maxilla and the mandible by making it smaller, and we have an actual increased incidence of TMD in patients with bicuspid serial extractions. When you expand, you actually create a larger footprint. So think about load distribution. When we develop the arch to that nice U versus a V, if you look at some of the most, the longest standing, freestanding structures in the world are the arches, the Roman arches. And there is a reason why it's called a dental arch. These arches have stood the test of time. They've taken up tremendous amounts of load. That's why when you have a bridge, the supporting pillars are connected to each other via an arch, because it's all about load distribution. The wider the arch, the better you can distribute the load and reduce the load on your TM joints. So this is actually the reverse. So if you have come across that, I would welcome that you forward that to me for review, and I'll be happy to write an editorial or a rebuttal to that. Because we know today with enough evidence that expansion does not cause TMD. We know anecdotally, even though the Orthodontic Society will not admit it, because that would be admitting failure and malpractice, and that would be it would create a massive class action lawsuit against orthodontists, that bicuspid extraction does in fact, just look within your own practices and look at all the young people or the middle-aged people that had undergone bicuspid serial extractions, the incidence of TMD in those patients versus a set of patients that didn't go through the serial extractions, and look at the incidence of TMD in those patients. You will find out, you will soon recognize that the set of patients that had bicuspid serial extractions have a higher rate of TMD within your own practice. We know that, but no orthodontist will ever subject themselves to a study to disprove, that TMD is not caused by retraction orthodontics. So they will never undertake that kind of study because it'd be admitting failure. I hope that answers that question. Oh, good. Glad to hear. Any more questions? Hey, Dr. Funshow. How are you? No, we don't do orthodontics. We do not do orthodontics. We're purely an appliance. You, as part of your practice, if you do headgear, that's fantastic. But, it's interesting. I have my own philosophy in headgear, but we can discuss that offline. Oh, so good to see you. So we don't use headgear. So explain to me the purpose of the headgear for oral appliance therapy. Headgear actually does what? It actually is to reduce the skull class 2, right? So the whole objective of oral appliance therapy is to actually move the mandible forward. So not sure what a headgear would actually do for oral appliance therapy. It's great for orthodontics, but not for oral appliance therapy, to aid in expansion in the sagittal plane. So we find, and I practice, traditional orthodontics as well as part of my practice. I use a lot of TADs to do that kind of expansion, to aid in expansion, to create the kind of forces that are required. I find that Headgear has a low compliance, at least in my set of patients. They just don't comply with Headgear as much as well, there's no compliance required with TADs. But I find that because the poor compliance with Headgears, the treatment efficacy is not as predictable as if we were to use TADs to attach a palatal expander to. Oh, you're welcome. I hope that answered the question. Yeah, so as our part of our platform, it's not an orthodontic platform, but we do have a huge section on pediatric sleep. But if you're looking at an orthodontic platform for your sleep patients, we're not it. We don't do any predictive modeling for expansion, at least not yet. That's one of our projects in the next 5 years. So we have a pipeline of different projects that we're doing. This is the next project is actually that three-dimensional oral appliance that can be titrated in both a AP and a lateral and a vertical positioning, because we know that airway is a three-dimensional structure, and trying to manipulate it in one dimension is really not it's really not sensible, right? It's not really really affecting much change, because how can you affect a three-dimensional change by manipulating something in just one dimension? You can, but you're not going to get as much of an effective change as if you were to manipulate the three-dimensional structure in all three dimensions. I hope that's kind of clear. Oh, thanks, Sarah. I'm glad you feel so. Questions. I guess we've exhausted all the questions. Perhaps not. You're amazing, Dr. Funsha. Thank you so much for your support. So appreciate it. Oh, you're welcome, Sarah. Yes, so why don't we do one thing? Just simply type in, what topic would you like to cover? Because now that we've covered the entire workflow, now we can have some real fun. So I'm looking for topics to cover at the next webinar. So either you can type it here, or you can shoot us an email as to what topics you would like for us to cover. And we'd be happy to do so. Okay, well, I guess we still have one question. Hey, Dr. Awazi, how are you? So the question is, do you have an opinion about the growth appliance in use in Europe and a few offices here in the USA to open airways? Hey, Daryl. Yeah, so Vivos is one of them. Dave Singh. We probably will be working on a project together where we'll be helping them with some analytics. But anything, Vivos is one. We have a few other appliances that are growth appliances, but realize something, anything that we can do to improve the arches, and in effect realize something, the maxilla is not the maxilla is a bone that's connected to the skull. The mandible is the only jawbone that is not connected to the skull in a fixed axis. It's on a hinge axis, right? So it's not part of the skull. So when you do mandibular growth, it's different than when you do maxillary growth, because the maxillary growth actually transfers into growth of other facial bones as well, not just the maxilla. That's because it's connected to some of the other bones as well, like the malar process, So, and it actually extends all the way back towards the soft palate. So when you actually do oral appliance therapy, and you actually do the growth with appliances that are growth appliances, it's very important that you pay attention to the extension of the appliance and what kind of where exactly is the change occurring. Because if you're just trying to do the growth by tipping the molars. That's not true growth. That's dental arch expansion. That's not true, alveolar arch expansion. And there's a big difference. So the question is, who utilizes these growth appliances in the U.S.? There are a few doctors who do. The problem with the growth appliances is they are fantastic and they work really rapidly in kids because you take advantage of the growth spurt. In adults, you can still do expansion. Those genes that are responsible for growth, the mRNAs, don't die off. Those genes just don't die off. They just get turned off. But they can be reactivated. And there are a bunch of really cool scientific rationale for how that can happen. But if you guys are interested, look up a guy by the name of Melvin Moss and look up something called the functional matrix theory. Pretty cool on how the subnewtonian forces actually causes alveolar expansion by stimulating osteoblasts in the PDL. It's, Melvin Moss. Look it up. It's fantastic stuff. I mean, this mind-blowing. And this was done, gosh, maybe 30, 40, 50 years ago. The man was just such a visionary, so ahead of his time. Oh, no, it's not risky. It's very predictable. It's very predictable. It's just not as fast as what you do in kids. So maxillary expansion. So, yeah, alveolar expansion, the actual bony expansion in adults is very possible and very predictable when done correctly with the right appliance, non-surgically. So you can look up Vivos Technologies. You can HomeoBlock by Ted Belfour. There are a few of them that really, really work. Yep, HomeoBlock, that's one. Yep, HomeoBlock. Vivos, V-I-V-O-S. Vivos Technologies has their own. And there's a few others, but those are the two really common ones. But the patent that we just applied for, and we have patent pending on it now, the appliance, actually, that's the first generation. Then the next generation, oh, you're welcome. The next generation of the appliance then is going to actually be a combination expansion oral appliance for treatment of sleep apnea as well. So you can actually expand and treat sleep apnea at the same time, because the way it actually works with expansions the way they are now is you have to first expand to get the airway and develop the airway, but they're not treating the sleep apnea condition in real time. But imagine an oral appliance that expands but is also treating the oral sleep apnea at night simultaneously. Yeah, so the question was, what's the other one? And so I'll just type it out. V-I-V-O-S. Vivos. I agree. I mean, having a combination appliance. So just imagine our first generation appliance that we're going to be rolling out, hopefully in the next 2 or 3 years, once we've done our 510K studies, is a multifunctional appliance. So you can treat sleep apnea, crowded teeth, for orthodontic purposes, TMJ, all with one appliance. So it's like the Swiss Army knife. Somebody described it by looking at it as the Swiss Army knife of oral appliances. No, absolutely. Oh, you're welcome, Sarah. Do we have any more questions? Well, if we don't have any more questions, I thank you all for your patience and the time and spending your Tuesday evening with us. Hopefully you learned something. Hopefully it wasn't a complete waste of your time. And if you're interested in finding out more, you can certainly shoot us an email. You guys have, I'll type in my personal email address. It's pretty straightforward. It's Dr. Pankaj Singh at apnea.com. Oh, you're welcome, Sarah. It's my pleasure. It's all about educating you guys, and people say that with education comes responsibility. I beg to differ. well, with knowledge comes power, right? I beg to differ. It's with knowledge comes responsibility. Once you know how to do something well, then it becomes your responsibility to transfer that knowledge into action. And if it's about patient care, then it's now your responsibility to take what you know and help your patients in the best possible way that they truly deserve to be treated. And the fact that you guys actually took the time out to spend it with me is a testament in your commitment to better patient care. So I applaud you for it. And please don't ever lose that passion, because I get goosebumps. You can't see it, but I get goosebumps when I say it. You guys are just amazing for taking the time and spending it with me. And I feel privileged and honored to have spent it with you. And I look forward to seeing you next time at the next webinar. And I really hope that you guys shoot us an email or call us and let us know what the topic should be that you're most interested in. And we'll be tabulating these topics that you are most interested in, and we'll tackle them one by one, and we'll keep adding to the list until we've exhausted it. And we'll record every single one of those webinars for you guys to revisit anytime, either on our YouTube channel or through our website. You can go to apnea.com and access the webinars and view them at will and on demand. You don't even have to be part of our network. You don't have to be a member. This is completely for you guys. If you feel that you can benefit even a little bit from what we have to share, then please, it'll be an honor for us to share that with you. So please do take advantage of it. And I wish you guys a good evening, the rest of the evening, and wishing you all just the best and tremendous success in your practices and helping your patients. And I applaud you for it. Thank you. Oh, you're welcome. Good night, everyone.